Now, some of you might be thinking, sure, there's a small risk, why not just stick with treatments I'm comfortable with, like massage or dry needling? They still help reduce pain and improve mobility. The reality, relying on only soft tissue strategies means you're likely leaving value on the table. For low back pain, massage and manipulation both reduce pain, but manipulation can deliver faster, short-term gains in mobility in those with mechanical spine pain that massage or exercise alone can't match. One study found that patients with low back pain who received only exercise were 8 times more likely to worsen after just 1 week compared to those who received manipulation combined with exercise. Neck pain is similar. Both approaches improve pain and function, but high-velocity cervical or thoracic thrusts speed up range of motion gains, helping patients progress faster in rehab. Some conditions respond especially well to manipulation. Cervicogenic headaches, for example, consistently show greater reductions in pain, disability, and headache frequency compared to massage or mobilization alone. Even better, combining manipulation with exercise, massage, or dry needling often produces synergistic effects, better outcomes than soft tissue strategies alone. So with all that being said, who stands to benefit the most and when? Well, for low back pain, early responders typically show a fear avoidance beliefs questionnaire work score under 19, symptoms lasting less than 16 days, no pain radiating below the knee, at least one hypomobile lumbar segment, and at least one hip with internal rotation greater than 35 degrees. These criteria captured in the lumbar manipulation clinical prediction rule identify a low-risk, high-yield window where manipulation can rapidly reduce pain and restore motion that you can reinforce with targeted exercises. For neck pain with mobility deficits or neck pain with cervicogenic headaches, thoracic manipulation paired with cervical mobilization, as well as deep neck flexor and scapular exercises, is usually the starting point. Cervical manipulation is appropriate when exam findings support it and safety screening is clear. The cervical manipulation clinical prediction rule identifies patients most likely to respond with short-term improvement and includes symptoms less than 38 days, positive expectation for manipulation, side-to-side cervical rotation differences of greater than 10 degrees, and pain with lower cervical posterior to anterior pressure. Using these guidelines helps tailor care to the patients most likely to benefit, maximizing effectiveness while minimizing risk. But think of these prediction rules as probability enhancers, not gatekeepers. They increase the likelihood of a strong response, but they don't define the only patients who can benefit. The reality is, any patient with mechanical pain, symptoms that change with movement or position, can potentially benefit from spinal manipulation. It's not just about the classic low back pain scenario. Think about an overhead athlete struggling with scapular control, someone with pelvic floor dysfunction due to increased tone of the pelvic floor, or even a post-op patient dealing with muscle inhibition. It's one of those tools that, when used appropriately, can help patients move better and recover faster, and that goes way beyond just getting someone out of pain.